So let's start this masterclass. So welcome everyone. My name is Stephanie Garty. I am the Chief Pharmaceutical Officer's Clinical Fellow working within the Transformation Directorate within the Digital and Interoperable Meds team within NHS England. I just want to welcome you all to this July's masterclass. So we're going to hear first from Andrew Staples, who is a team leader at the Cleveland Clinic in London. And after Andrew, I will be speaking to you and giving you a presentation of the projects I've done this year. And then after that, we'll be talking about the new community of interest of community of practice that's going to be relaunched. And so no further ado, we'll start with Andrew. So Andrew, I'll take it away.
Hi, how you doing? It's been a while since I attended this, so apologies for being late. Oh, I'm unmuted again. Can you guys hear me? Can you hear me now? Okay, don't know what happened then. So hopefully what we're going to be doing is going through some of the implementation of the pharmacy and IT solutions at Cleveland Clinic London, directed at the pharmacy, which is what I've been working on for the last 4 years. Going through some of the novel workflows and some of the novel structure that we've done. So if you change slide, please.
It's just not doing it.
And down again. Thank you. So hopefully you can see this okay. It looks like the bottom has dropped off mine a little bit. Thank you. So what we're going to do is kind of walk around this busy slide a little bit and just talk about some of the technology integrations that we put into Cleveland Clinic London and why we did that. So starting with what the pharmacy is aiming to do. So Cleveland Clinic London is trying to mirror an enterprise pharmacy approach, which means that the entire Cleveland Clinic enterprise, which covers North America, Canada, Abu Dhabi, and London, all work roughly the same way using very similar technology and automation pieces. And as part of that, we're running a decentralized workflow, which means we're trying to hold stock more at the ward level, and also running a unit dose type workflow. We're not the first people in the UK to do a full unit dose workflow. We've got to take our hats off there to University Hospital Leicester, who did a pilot for the last few years. And our workflow isn't that dissimilar to theirs. So if you've seen some presentations from Leicester, it's very similar to a degree. I think the thing that we're doing slightly differently is what's in the top right corner there, which is the Swisslog Therapic. So part of, well, I guess go back a step. So one of the aims of our pharmacy as well is to make everything scannable, and that's partly where the unit dose section comes in, but it also applies to all our whole pack medications. So as part of the function of our pharmacy, and when we started out designing it, we even looked at our medications that we were contracting to make sure that they had barcodes on wherever possible, so that every single product at the inner level, so that's not the box that you receive it in, say like with IV fluids, but the actual bags or the actual vials, wherever possible, we tried to contract stock that had barcodes. And anything that didn't have a barcode on the inner pack level, we then looked at unit dosing and how we would achieve that. And that's where the Therapic comes in. So the Therapic is a large robotic piece. If you're not too sure how big that one is, it's about 9 meters in length, and it's about 2.5–3 meters high as well. And depth is about 5 meters. So it's a big piece of machinery, pretty complex. And what it does is it creates unit doses. So you can load in medications like tablets and capsules. It will create a map of those that you approve and then cuts them up and wraps them to look like unit doses. And you can sort of see a unit dose in the middle of the screen. It's like a little white square, rectangle with the medication in there. And it also labels it with the product's information, its expiry date, its batch number, and crucially for our workflow, a barcode. And we're going to talk about the barcode slightly later because we've done something unique there too. Generally, the barcodes that we're using are all GS1 and they're all 2D data matrix barcodes. The other thing we've done here, which is the same for the carousel, which is kind of as we move around that slide, is we've integrated them. So the carousel, the Pyxis cabinets at the ward level, the C2 Safe, and the Therapic are all connected by a formulary interface. And what that means is that we can set up through our EMR, so our hospital system, which is Epic in this regard, the same product IDs and share them with the same information through all the solutions. And what's beneficial there is that we have one ID structure for all the medications that is mirrored through all the automation pieces, but we can also standardize the names, the forms, and all the rest of the medication information that is generated by an IT system in its database and standardize it. It also means that we can, by updating Epic or EMR, we can also update all our automation pieces at the click of a button for all those new items. So we're not necessarily touching every solution every time to create a new item, so replicating it 4 times across the different automation pieces. We are literally doing it once and then doing any custom updates within an automation piece where needed. The other interfaces that we have running, which doesn't apply to Therapic at the moment, but will do in the near future, is something called a load and load interface, which means that it keeps our EMR up to date with its stock levels. So we do all our procurement through the EMR itself, and then every automation piece is feeding its balances and any dispenses and any transactions through to the EMR formulary function, the purchasing functions, so we can then coordinate our purchasing through one solution. And if you've never had to deal with interfaces, that's a lot of work there, just as a heads up there. So the carousel, which is the bottom right-hand corner, is again an automation piece from the US. This is part of that enterprise workflow that we were honoring. It feels a little bit outdated to a degree when you first look at it and see a large robotic shelf item that you're picking the items from. And in truth, that's kind of how it looks and feels, but it's very efficient. It also has a very high level of storage, and also has a very high adaptability of storage. So you can store fluids in there, you can store bottles, liquids, amps, lots of different things. So you can basically use everything through the carousel. What makes it very functional in our workflow is its software. And it has a software package called Logistics, and again, we're the first in Europe to really use this. And what that means is it's communicating very closely with Epic or EMR, but also the Ward Pyxis machines. And so the Ward Pyxis machines can reorder themselves automatically into the carousel, and it can organize our workflows for that. So we gain a high level of efficiency through the automation and the software, even though we have maybe a slightly more manual robotic solution in the process. Bottom left-hand corner, we have the C2 safe. So this is our primary automation piece for storing controlled drugs. No controlled drugs is stored in Therapic or in the carousel. And we are paperless to a degree due to in the pharmacy for all CD storage and registers, and the same at the ward level as well with the Pyxis devices. So all our registers are paperless, and the C2 Safe and the Ward Pyxis devices communicate between themselves to help us coordinate stock updates and automating the replenishment of CDs at the ward level. Again, we're not the first to do that one in the UK fully. I believe Colchester, I think it is, who run the C2 Safe and I think Ward Pyxis devices together and do that coordination as well. So that's kind of a brief tour of this slide. I guess the key take homes here are there's a lot of automation pieces. Those automation pieces are not purely within the pharmacy themselves, although there are a significant number. We have all ward locations and medication storage locations outside of the pharmacy have an automation piece in terms of a Pyxis device. All our medications are barcoded and can be scanned in every single automation piece. We also integrate all our automation pieces with the EMR so that we can standardize the product IDs, and we try and track stock at all locations as well. Can we move to the next slide, please? A bit more about that decentralized workflow and a little bit now on sort of pros and cons as well with being so automated and having such a complex setup. One of the things I briefly talked about is being decentralized. The aim of that is to have the majority of the stock at the ward level that the nursing team are going to use. And the reason for that is that it's fast, because the easiest way for a nurse to get a medication is not through pharmacy, it's from the cupboard that's right next to them or the electronic cabinet. And so by controlling the stock and the formulary very closely and making sure that all the medications are stored locally, you can achieve a very fast turnaround for any medication started. Now, we're aiming to be about 80 to 95% of all medications stored at ward level that the nursing team would routinely use. Obviously, there's going to be more ad hoc medications that need to be dispensed by pharmacy. And the nice thing here is we run a process where we try and add it to the stock temporarily. So using like a temp stop function where we, instead of dispensing this patient specific, we would try and create a temp stock and load it into that ward Pyxis. And so it follows the same workflow. So on the first dose, there may be a small delay while it gets sent up. But after that, there is a routine workflow where they're just taking it from the ward Pyxis devices. The ward Pyxis devices are the ones where you have a QB. So I'm not too sure if you've seen a Pyxis device, but they have two drawer sections. One is called a matrix, which is a large open drawer section with dividers. And the other ones are called QBs, where each section is in its own little container. And so all our unit dose medications are largely in these QB locations. And so when the nurse accesses the Pyxis cabinet, the drawer opens and there's only one individual section opens up. The nice thing about that is you can control very tightly which medication is accessed, but also you can set par levels very easily for each section. What that means from an automation and workflow point of view is that all our medications at ward level have a par and a maximum and minimum, and that coordination can be sent through to our dispensing carousel so that every day on a schedule, if a Pyxis cabinet is running below par or hitting a critical low, it will automatically order itself on a set schedule to be dispensed and sent up later that day. So again, driving that efficiency through the automation pieces. Now, that's a little bit atypical for the UK. It's something we probably want to strive to. What it does mean is that our dispensary is covering many workflows, which means it's very efficient because all our workflows channel through the same automation pieces. But what it does mean also is we've got to be very organized with the staffing and look at the and the scheduling of work throughout the day. So the pharmacy does run a 24/7 service, which is a little atypical for the independent sector. But what it does mean is we can organize our work any point of day. So for example, we might organize for the theater Pyxis devices to reorder at 8 a.m. or 6 a.m. before the theaters start, and make sure that they're all topped up with any medications that are due to be done that day. And then we can spread out the rest of the ward and Pyxis locations throughout the day so we don't hit any really high spots. And we can also adjust that so that if we're getting, say, peak demand on discharges and TTO workflows, we can adjust our Pyxis replenishment workflow time so that they separate away from that. So the goal is by using the technology to coordinate when we're doing the work, we can spread the work. So even though we have a small crew, we can utilize them very efficiently to deliver all the medication requirements. Now, one of the things that you might be occurring to with such a, I guess, an automated pharmacy is what are the problems? And I guess the problems, there can be quite a few. So automation is good for efficiency. It's good for storage. It's good for coordination. Because all our medications are tracked with data matrix barcodes, we have really good information on expiry dates, batch numbers, all that stuff, as well as stock levels. The downside is you've got to be highly coordinated. And your system is very rigid. So workflows where you just go, oh yeah, this patient's brought in this inhaler or this cream and they want to use it, are a little bit harder to support. And we have to create exemption workflows where how they can be used and stored. So for instance, creating fake medications or fake patient assist workflows so that you can store them in the Pyxis or you can access them as you need them. The other downside to high levels of automation like this and with integrations and support is you need a very big IT team to support them. So you need a lot of support for your clinical applications and clinical informatics teams because this takes a lot of design to set up and it takes a lot of testing and maintenance to maintain. That's the drawbacks. Efficiency gains, yay, safety gains. Downside is you need complex IT and you need experienced maintenance crews. Next slide, please. The other aspect here is we've not just limited this to the main dispensary sections and the wards and how they're communicating, we've also done this to our aseptic unit. So all our medications in our EMR Epic for infusions and injections that are made to our SIVA service are all built and can be prescribed and dispensed through our EMR. That's nice in terms of being able to then use one system to do everything. We've then also looked at the IT infrastructure to support that. So we've got dispensing cabinets with, isolators with integrated screens so that you can see the preparation instructions and information that you would need to make these. We also have document cameras installed into those and in the workflow so that images of vials, ampules are taken during the workflow and can then be referenced out to support staff. So QA pharmacists or people checking the amps and vials to confirm volumes and ingredients going into the mixtures. And make sure that we have a tight QA process all the way through. And we've gone through an appropriate QA process to validate these workflows as well and sign them off for the UK. There's a little bit of truth coming. Our aseptic unit built itself is behind schedule. And so we are running this workflow, just not within the isolators at the moment, which means that everything's got an immediate expiry, so within 1 hour of use technically. But we are technically using all the technology on the screen to a degree, maybe not the isolator, but we are certainly using the touchscreens and the document cameras to run the workflow. So we're the first paperless workflow using Epic as the EMR and dispensing system in the UK to do this, but it's been very successful so far. Next slide. And again, like we mentioned, the technology that we implemented and the infrastructure does not stem just to the pharmacy. So at the ward, starting with the Pyxis, we've already described that all the medications at the ward level are stored within a Pyxis device, usually within QBs, and that we are aiming to store 80 to 95% of items at the ward level to minimize turnarounds. We've also made sure that as the nursing team are accessing and the physicians are accessing the systems, we're trying to make sure that all the information that they would ever need is at their fingertips. So we've worked very hard to make sure that things like the BNF and the monographs and linking out to the correct medications is as seamless as possible and it's easy to do as you're doing the prescribing. We have integrated pumps, so they're not fully bidirectional yet, but they are fully bidirectional integrated pumps. If you're not too sure what bidirectional pump is, it means that you can push the information from your EMR to the pump. So you can say, this is the dose and the rate that this pump needs to run at, and it will take that information. And it can also pass information back as, say, the volume infused or the amount infused. And if you've got that set as a PCA, obviously then equivalent functions for PCA and epidurals based on the pump types. So we're not there on the full bidirectional function, but they are up and running as non-bidirectional integrated pumps currently. And our project there will be within the next 6 to 12 months is to switch on the bidirectional function. Because we were designed from scratch to be able to run a unit dose workflow that's fully barcode compliant, we have a 90 to 95% compliance at go live and still running for medication administration. So every single medication we are producing has a barcode on it, a 2D barcode that contains batch numbers and expiries. All of them are scannable, and all of them are compliant within the BCMA workflow. What we also do is create a charge on administration workflow as well. So when we generate a patient level charge, it's off the administration of the medication, not from the pure dispense. And so we are aiming to be very honest with how much we're going to charge a patient for each of these medications. That's also relevant to the NHS as well. So one of the things I used to do at Adam Brooks before moving to CCL was do reporting and charging and billing for pharmacy. And patient level charging, even though we don't bill the patient, is really key because it allows you to say how much resource cost a patient visit has. And so utilizing a similar structure in the NHS is very valid because you still need that information to know how efficient your process is in terms of resource. So we have a lot of technology at the ward. Oh, sorry, I missed one bit off. So with our ward Pyxis device and our EMR as well, we have a FHIR integration technically where we can send dispensers through to the Pyxis cabinet from the EMR directly at the nurse's request. So to make it more efficient for the nurse in the medication rooms, we have a function enabled that allows them to queue up all their dispensers. I think Omnicell have a similar function called Anywhere RN, and allows the nurse to then just walk to the Pyxis machine, scan their badge to access it, use their finger to scan in, and then they can see all the medications they've pre-ordered, and then the drawers will open in sequence to get them. So if you can move to the next slide, please. This is to cover some of the information about the barcodes themselves. Can you just tap down? I don't know if there's like a stack of arrows that appear. I can't remember how I set that up on this. There you go, thank you. I mentioned at the start briefly about our unit dose barcodes and there being something unique about them. So anything that we produce through the Therapic robot, we have highly configured barcode that includes the CCL ID as well as the GTIN from the actual whole pack barcode. And it's a complex structure, but we've done it for a very specific reason. We wanted to make sure that every single product we produced, we could link back to the original manufactured item very closely. Not just that we had a shared code, but also we know exactly what product we scanned at the point of generating it, its expiry, and its batch number. So every CCL barcode generated by Therapic contains the original manufacturer's barcode itself and its expiry and its batch numbers. Sorry, let me just make sure I said that correctly. It contains the manufacturer's GTIN, its batch number and expiry, and where it's available, a unique ID sequence as well. What that means when we scan is that within an automation piece, we can scan the medication using a CCL ID, which is also a 14-digit GS1 compliant unregistered code, so that every system understands the product. And then when we scan it within the EMR, it can recognize the manufacturer's GTIN, drop a charge based on the original purchased item. So this is where we're being honest about how much we're charging, because we link it back to the physical purchased item. And we record a batch number and expiry. So anything that's scanned has a valid batch number, which is great for recall. And we will also prompt the nurse and the physician if the scanned medication is expired at the point of administration. It's a bit of a complex piece of information. And I have done a presentation actually on that one at the Congress. So happy to go into more detail if needed, but realize I'm close to time. So if you can tap down, that's kind of it. So happy to take any questions and go through anything else.
Yeah, Andy, there's quite a few questions in the chat, and thank you for your presentation. And it's really good to see how automation is being utilised in the independent sector. And I hope for the audience, it's a way to think about how we can use and utilise automation for the NHS, because I think there's a lot of principles and a lot of things that we can still use. Even though I think a lot of quite a few trusts are quite behind in how far we are automated, it's food for thought about future processes. So there's a couple of questions in the chat about are controlled drugs processed in the same way as other drugs, and how is this linked to the CG register, given that you said it was a paperless process? So how do you do how do you process without wet signatures?
Sure. So in terms of procurements, everything's procured through the EMR in the same way, and obviously we have a home office license for storage and got all our storage and solutions approved through the home office and appropriate workflows and appropriate bodies. C2 Safe generates its own registers, and those are, again, were signed off by the home office as part of the process. Each Pyxis device stores a register as well for every single controlled drug, and again signed off by the home office. So in terms of storage and registers, as long as the workflow is compliant and the devices are compliant, that matches the legal and ethical requirements. In terms of workflow ordering, what the C2 Safe can do is looks to every single Pyxis location and says, is your CD count below your par or at your minimum? And if so, do you want me to order it? And when we do that, we generate a piece of paper. So that's where I said paperless-ish, and so we use that as a delivery slip, and so we get signatures on the delivery slip, and then we scan them and store them. So our registers are paperless, but we do need to use paper in sections of the workflow to make sure that we are fully compliant in every area. We have looked at technology to bridge that gap as well. There's a couple of things that are potential solutions to that within the EMR solution itself, but also within Pyxis. We didn't feel they were worth the risk for Go Live because we were very focused on activation, and we didn't want to hold up our MHRA sign off and our regulatory sign off, because that would have been a big issue. Does that answer your question, hopefully?
Yeah, I think it does. I'm going to ask you one more question and then we'll have to move on. But there are more questions in the question section. So I don't know if after the webinar, if you don't mind answering the questions, then we can send it out to delegates. But the last question I wanted to ask you was about automation and staffing. And have you had to reduce the amount of staff you have had due to the automation process being brought in?
It's a
And
good
has it
question.
reduced your drug spend as well?
So I guess the thing to remember here is CCL didn't exist as a hospital until the end of March. And so we have always been designed from day one to be this automated. So our staffing levels have always been reflective of what we thought we would need to run the pharmacy and the 24/7 service that we are envisaging. So I would say our staffing is low, and it's probably too low for the pharmacy, and that we do need more people, particularly to cover all the shifts. The fact that our aseptic unit wasn't fully functional at go live due to some building issues created additional work requirements and increased staffing requirements, because we can't do anything with more than an hour expiry. And so we are struggling on those fronts too. But in terms of if we were to implement this level of automation in an established hospital, I don't think you would find you reduced your staff. What I think you would find is you change what they would need to do, but also you wouldn't necessarily need to keep increasing staff levels to account for increased workloads. What we would do is, or aim to do with such an automation, is make sure you can deliver the service that you want at the speed and efficiency you wanted, but also looking at how you optimize what everyone's doing.
Okay, that's a great answer. Thank you, Andrew. And thank you for presenting today. If you do have any more questions, please continue to put them in the question box below. But thank you, Andrew.
And if anyone has any questions after this, and if you don't have my email address, feel free to reach out through staff or anyone, and happy to take any questions.
Cool, thanks. Okay, Georgia, can we move to the next slide? Thank you. Okay, hi everyone. So instead of me chairing, I'm going to be presenting my project and what I've been working on for the past few months whilst doing my fellowship within NHS England. Okay, if you have any questions about my project or what's been presented, please feel free to put in the question box down below as you have done. Okay, next slide, please. So just to give you a brief introduction, so my project's been looking at interoperable consolidated medication records, and so basically looking at interoperable consolidated medication records. Can you move to the next slide, please? Okay, and it was just looking at the exploration. So with new models of working, models of care emerging, so with the emergence of the ICSs and ICBs, and we know there's a clear need to share information more effectively between different care settings, organisations, and across different geographies, so regional boundaries as well, and not just for healthcare professionals, but also citizens, to optimise patient outcomes and optimise quality of care given to our patients. However, there is an increased reliability on reliance on looking at our electronic systems and whether they can actually talk to each other and whether they're interoperable enough with one another. And this interoperability is key for the delivery of the future vision of healthcare within England. So my project was basically looking at the exploration, understanding, and the readiness for interoperable shared medication records or consolidated medication records, however way you may use it. And in this presentation, I'm going to be using shared and consolidated records interchangeably. So the aim of my project was, again, exploring the impact of implementation of a consolidated medication record across all sectors within the NHS. Some of the objectives was basically to find out the benefits, the challenges and the risks with implementing a record, but also to review some of the health, social, and economical and cultural impacts it may have when implementing such records. Some of the methods I used during the project was mainly doing literature searching, but also doing exploratory, semi-structured interviews with a whole host of stakeholders. And again, because this project was started in November, December time, COVID did impact on some of the methodology, but I think using Teams and using Google Chat, I was able to reach a whole host of different stakeholders. So if we move to the next slide. So some of the people that I did speak to are on the screen, and including at the time the Chief Clinical Information Officer for the NHS, Simon Eccles, as well as the Chief Information Officer, Sonia Patel, as well as a whole host of different stakeholders that you can see on the screen, so including subject matter experts in digital inequalities, technical architects, and pharmacists, and nursing staff and frontline staff, as well as those senior staff members as well. Okay, a more comprehensive list will be available in a report that's due to be released later on in the year. Okay, move next slide, please. So I think some of you may be wondering, what do I mean by interoperable consolidated medication record? So as you can see, interoperability is basically the ability for computer systems or software to basically exchange and make use of information. So basically share the information easily and have a good flow between the different systems that we come across. A consolidated medication record, however, there isn't a dictionary, there isn't a definition within the Oxford Dictionary. So the definition I've got on the screen is basically a consensus definition from my program team within the Transformation Directorate and NHS and digital teams. And what we've come up with is a complete visibility of a patient's medications from any care setting, including the patient's own medication. There will be, however, later on this year, a more official definition once the Faculty of Clinical Informatics have completed their work on rendering work on shared medication records and interoperability. Okay, next slide, please. Okay, and so as you can see on the screen, this is the digital medicine's ambition for having a seamless transfer of medicines information, which is basically bidirectional to allow for seamless transfer of care across any care setting, and for allowing to have a consolidated medication record that includes primary care data, but not just GP systems, but also other community services such as dentists, optometrists, community pharmacists, mental health, sexual and substance misuse services, and a whole host of others that have not been mentioned, as well as including home care prescriptions, as well as secondary and tertiary care. And ideally, having this record will be able to be viewed within an ICS or region, and greater ambition is for it to be available nationally. Next slide, please. Okay, so here's some background into policy. So with the introduction of ICSs and ICBs from the 1st of November, 1st of July this year, we need to have more integrated ways of working, and to, like I said in the beginning, to enable to have care professionals and citizens to better manage their care. So we need our organisations to be able to work together, and having interoperability is the key to delivering these new care models. As you can see on the report from 2016, from the Watcher report, he mentioned having a new effort to digitalise the NHS, and you need widespread interoperability to enable to have this widespread digitalisation and enable the seamless care delivery across the normal organisational boundaries that we do have, and so that every patient can access all parts of the clinical record. In the long-term plan, again, it mandates having that technology standards are rigorously enforced, and to ensure that data is interoperable and accessible, and so that every supplier within the NHS needs to comply with open standards that have been published. Again, in the Good for You, Good for Us, Good for Everybody over-prescribing report released last year, again, talks about having a shared medication record is the key to tackle over-prescribing and also improve shared decision making between a clinician or care professional and the patient. Next slide, please. This isn't a new concept. I don't know, some of you may remember this report back in 2001 called A Spoonful of Sugar. And again, in there, it talks about having this computerized prescribing that's linked to a patient record. And again, so like I said, this is not a new issue. In 2001, that's over 21 years ago. So yeah, okay. So next slide, please. Okay, so I'm going to talk about some of with my discussions. with the different stakeholders as mentioned before. And these are some of the benefits that I was able to collate from all the different stakeholders. So the three main benefits of having an interoperable shared medication record is, one is the improved patient experience. So we're thinking about patients being able, and also clinicians having a holistic view of all the medicines that a patient may be on, rather than I don't know if you when you're doing medicines reconciliation, sometimes what you initially thought the patient is on is not what they're on, and you have to keep going back and forth between different sources and between the patient or carer to find exactly what they're on. And with this, having this holistic view, we'll be able to have a better understanding and be able to have an improved patient-clinician relationship, and with this having increased shared decision making on the part of the patient, so the patient is more involved in their care. As well as this, we'll be able to view medicines as a whole and hopefully be able to reduce health inequalities because we understand what's going on with the patient, rather than having 10 minutes of trying to find out exactly what they're on. Within those 10 minutes, it could be better utilized to find out what the actual problem is. Which leads on to having improved patient safety. Having this holistic view will allow for having a more personalized care with the patient, because you know exactly what somebody may be on without having to have to ask the repeat questions. As well, with that, having improved efficiencies, it will help to reduce the amount of transcription errors that occur. And so we're not rewriting every single thing that a patient may be on, because it's there ready and waiting for us. Administration tasks as well. And not only that, with this, having a holistic view of what patient is on, hopefully will help with reducing medicines wastage and help with the sustainability cause, and help us to not have so many reissued and redispensed medicines when we know exactly what somebody is on. Next slide, please. Okay, so with having an interoperable shared medication record, like I said, we'll have a new strategic direction for pharmacy. So thinking about we'll be able to move away from ill health and ill health management to more preventative and population health management. So like I said before, improved efficiencies, such as having reducing administration tasks and having an increased perceived more time for clinical tasks, as well as actual having shared decision making. So rather than being a paternalistic relationship that we have with patients, again, it will be more shared and more collaborative relationship. This will allow for more of a coordinated care and delivery. So again, the patient will be will have more time to explain with the patient about the medication and their health issues. And this will allow to having a truer integration of health and social care. So the patient's able to see all the medicines, again, that will allow for a patient to have greater autonomy with their health, and also allow to have transformative healthcare in the future. Okay, and next slide, please. Okay, so again, talking to the different stakeholders, there was a word that kept on coming up, was talking about having this interoperable consolidated medication record as the single source of truth. So being able to see all, like I said, have that holistic view of medicines. And when we're talking about single source of truth, these are the things that people were saying that should be included. So things like having your acute prescriptions, so across repeat prescriptions, having your hospital only prescriptions, so prescriptions that may be prescribed only in secondary and tertiary care, having your home care prescriptions as above, and your medications that are prescribed from all the different services and community services that I've mentioned before, as well as eventually be able to see your over-the-counter and pharmacy-only medicines. What else needs to be included is talking about allergies, sensitivities, and intolerances. And again, that brought up a bit of an issue. So what's the difference between allergy, sensitivity, and intolerance, which needs to be decided? There was also some talk about having indications. I don't think you can see on the screen, but having indications written for all the medicines that have been prescribed or on a record. It was funny talking to the different stakeholders. So pharmacists wanted indications written. However, some of the other clinician types, such as nurses and doctors, didn't necessarily see a need to have an indication on there. So that's another thing to, once you're on your strategy to implement, and it's something to discuss as a whole and as a team, what do you think is important, having an indication or not. Also, the other one is talking about dispensing information. Again, this is another thing that pharmacists, those with pharmacy professionals, wanted this dispensing information, but a number of the clinicians, other clinicians, didn't necessarily think it was necessary. Next slide, please. Okay, so talking about, there were some concerns expressed for accuracy and accountability for the content within an interoperable consolidated medication record. Differences about occurring between, what's the difference between accountability and responsibility? Different views about having collective or individual responsibilities for keeping the accuracy or the content of the record going on. So having a collective responsibility, so each sector is responsible for their record, or potentially having a caseworker that's responsible for the whole record keeping. But again, this is something that needs to be worked out as part of the journey of having an interoperable consolidated medication record, and will need to be worked out in the team when you're embarking on this journey. And also talking about accountability, does it just lie with the clinician who's prescribing, or does it rely on or the person who's changing the record, or does the accountability ultimately lie with, say, the GP? Because at the moment content is prescribing normally is, and healthcare is normally accounted to the GP. Next slide, please. Okay, again, one of the big things that we need to see is stakeholder engagement. So it's really important to have patients and citizens at the beginning of the journey, and not introducing them at the end, towards the middle or the end of the journey. Most patients, and clear, concise messaging is needed. So most patients actually see the NHS as one vehicle rather than the separate fleets that it actually is. So most of them actually think that information or their data is already shared between the organizations. So embarking on this, you need to, again, acknowledge concerns that patients and citizens will have. Patients themselves are more likely to want their data shared between the different organizations. However, citizens, as we know, when we think about the GP data set and scandal from last year, won't necessarily want their data being shared. So you need to be able to have clear, concise messaging, and be able to acknowledge any concerns and actually act on them. It's really important to take your citizens with you, as you can see from this Goldacre quote. It's really important that you rebuild on our privacy and transparency and build the trust. It's not done by communications and public engagement alone. Actions are really needed in order to for citizens and patients to be involved with this. Okay, next slide. Okay, and another thing that came up was user-centered design. So the view of the record needs to be patient-centered, it needs to be intuitive, accessible, and easy to use for all users, not just patients, but also clinicians too. And it shouldn't exclude depend. And when we're talking about the view, some people had mentioned having different views for different professions. I'm not sure that's necessarily the right thing to do, considering that a lot of our professions, so pharmacy, and we're talking about physiotherapy, we're talking about other therapy roles, and nursing roles have extended roles, and so there is a need, to have holistic care. So I do think there is a way to having views available that are the same for all clinician types. We need to make sure that the information is available to all, and everyone who does have a right to view, has a legitimate right to access the information there. We also need to be thinking about accessibility of the data or the record, and how can we use this to tackle inequalities, and not just thinking from patients, but also thinking from staffing, thinking about digital maturity, thinking about connectivity and literacy, and thinking about data poverty as well, and trying to use this as not as a way of creating a two-tier system and creating another form of inequality. So like I said, it's really important from the get-go to be thinking about the different ways people can access their patient-centered interoperable record. Next slide. Okay, now we're coming up to closing up. So it's really important when you're implementing this interoperable record is to think about your internal priorities. Think about what's going on in your organization, what's going on in the ICS, and what's going on in your region as well. Because sometimes it's really easy for this not to be a priority. Also to think about the differing digital maturities that may occur across different trusts, across an ICS or across a region. What IT infrastructure do you have and what do you need to be put in place to have such a record? Also thinking about your suppliers, it's really important, like I said, stakeholders, and to have your suppliers from the very beginning and while you're on this journey. Thinking about the timelines, are your timelines realistic? Like I said before, and when we go back, thinking about information governance and what should be shared and what shouldn't be shared, and having a frank discussion, remembering that a shared record is a primary delivery. It's a primary delivery care, and remember the arrangements that it shouldn't be a blocker as to not to have an interoperable shared record. Think about the resources that you have or the resources that are needed for this, including like education and training, as well. Next slide. Okay, so top tips for implementing a record is that you need clear, good clinical leadership. You also need to have a clear shared vision amongst your different stakeholders and include your patients with you. So next bit is taking everyone, including the patients with you. It's really important to your information ISN standards are baked in from the very beginning. So we're talking about things like SNOMED, we're talking about DND, we're talking about FHIR, we're talking about those syntax are baked in from the very beginning. And remember that it's a journey, there will be ups and downs, and it's important to iterate. The first version won't be your last version of this. Next slide. Okay, and that's the end. Thank you for listening. So I'm just going to answer a few questions that are in the chat. Okay, the slides will be available later on, and it will be put on the Feature NHS site. Okay. So someone's asked a really good question regarding single source of truth lists. Where will it be stored? Is it by the GP? Is it ICS or National Patient Health? Again, this is just an exploratory piece. So again, it depends on your ICS, your region. Whoever, once you decide to embark on this record, it's up to the team or the organization to decide what exactly they want to be on this record. This is, my report is just an idealistic view of what it should be included, but again, it depends on the organization and what you've deemed to have that single source of truth, or what needs to be included, and what can you actually, and what's realistic, what can you realistically include as well. Okay. So yeah, so someone's put something about having risks, and yeah, it's really important that when you're embarking on this, again, thinking about your cybersecurity, thinking about information governance, and like I said, it's having those deeper discussions about what should be shared, how it can be shared, and who's got the actual legitimate right to access the information. So if we're thinking about things about the latest Gold Acre report, we need to and the latest digital strategy that's been data strategy that's been released, it's really important to be thinking about data sharing. And it's, again, these are conversations that need to be had and need to explored further, and it can't just be done once, it needs to be explored all the time. Okay, thank you everyone. I'm going to move on to our next topic, which is the introduction of the community of practice. Okay, next slide please. Okay, sorry, excuse the time, we had some technical difficulties in the beginning. So I'm going to talk about listening to your concerns. So myself and Paul Wright, who is engagement lead for standards implementation at NHS Digital, we have decided to relaunch a community of practice, community of interest for the digital and interoperable medicines program, which is on the Feature NHS site. I think last masterclass I'd asked you to complete a survey asking whether you would like a community of practice or community of practice. And we got of the replies that we got, every single person who replied had said yes. So we've explored this, and we decided to relaunch the community of practice, and given the feedback from the masterclasses as well as the digital medicine event that happened on the 27th of April. So next slide. Okay, next slide, please. Okay, so this is what it looks like. So I don't know if many of you have been on the Medicines Optimization Digital Learning Network page lately. So we've just updated it and made it a bit more user-friendly. That's on there. So this is the first thing that you'll see when you go onto the page. There's a carousel going on talking about the masterclasses and what's available on the sites. Next slide, please. Okay, so we've got we've updated the landing page. We've also put some, been able to put some do's and don'ts of how to use the site, as well as a search function. So if you want to look for any resources that may be on there, it's easily searchable. Next slide. Okay, and on there, we've got a link to community of practice, which is basically, next slide, a list of forums for all the different areas that people had mentioned that they were interested in. Also at the top right-hand corner, there's a place to subscribe for different alerts. So we've got all these different forums. So talking one about careers and personal development, another one talking about future developments that are occurring nationally. One about implementation. So those of you who are involved in the implementation stage can go into implementation forum. We've also got optimization forum, as well as a pharmacy technology forum for those who are having troubles or have any queries about the terminology, specifically DMD or SNOMED. We have a procurement forum, so for those who are in the procurement phase of the ePrescribing or digital medicine systems can use that. We also have a resource forum, so where different people can discuss about, and colleagues can discuss about sharing resources. Also have a forum for those who would like to speak at future masterclasses as well. We're able to put that on their forum, as well as a supplier forum. So it's an arts for colleagues and to discuss system suppliers. It should be a safe space if there's any challenges that have been going on, and also as well as another forum for topics from the ePrescribing Masterclass. Please let us know if you think this is too much or too little forums, and we can always change and iterate. This community of practice is for you, so it's always we're always amenable to changes. Next slide, please. Okay, we also have a place for resources, a resource library as well. Next slide. Okay, and we've also developed a network directory as well. So this is a space, next slide please. So this is a space where you can share your contact details, you can find other like-minded people who are in similar stages of their digital journey. Again, this is a space, feel free, you don't have to, but if you do, this is an interactive space, so if you feel free to put your details down, and so you can link in with others and know what's going on out there, what's going on nationally. Next slide, please. Okay, so here's some slides. These are some links to the Future NHS page and the Community of Practice page. Also, the Community of Practice survey and feedback survey, which some of you have already completed, is still available to complete up until next week, Wednesday. So feel free, now you've had a look at the site and you've given me a bit of a taste there, feel free to complete the survey and give us any feedback about how we can improve the site. Next slide. Okay, and that's it. Thank you guys. Thank you for listening to this July's masterclass. Thank you for all those who've put questions in, and thank you to Andrew for his presentation at the beginning as well. If you have, if anybody would like to present at a future masterclass, please feel free to email myself or Sarah, and the contact details are on the next slide. going on. The next masterclass is on the 14th of September between 1 and 2. Again, like I said, if you have any ideas for future topics or any feedback, please email Sarah. Also, please remember to use the hashtag ePrescribingmasterclass on Twitter or on LinkedIn as well. As well as that, please join our learning network. So what I've spoken about, the community of practice, that is on NHS Futures. Cool. Thank you, everyone. Thank you for coming along. And again, the next masterclass is on the 14th of September.